Hi, everyone. Welcome to Perfusion Musings, the podcast from Envello Medical, where we're diving into the science of perfusion, oximetry, and the future of cardiovascular care. I'm Casey Bowell, CEO here at Envello Medical.
And I'm Dan Rodenhaver, our Chief Commercial Officer. And today we're joined by Dr. Noelle Saillant from Boston University School of Medicine, and she's Chief Medical Officer, Chief of Surgical Critical Care at BMC Boston Medical Center. She's also a proud BU alumni, where my daughter will be matriculating, and I appreciate you being willing to give her some guidance. So thanks for being with us today.
Yeah, it's my pleasure. Thanks for having me today.
Noelle, we've met at a bunch of different conferences, and I've had a lot of opportunity to learn from you in conversations sort of in the margin and while you're speaking. And one of the things that's been really helpful here is for us to understand how perfusion changes between cardiovascular disease and in trauma. And with so much experience in trauma and surgical care, and with the potential for patients to decompensate very rapidly, I'm really interested to share with our listeners your perspectives on how physiologic signals can degrade and which ones you use, and whether the way that you currently monitor perfusion is really truly accurate. Can you expand on that?
Yeah, well, that's a complicated question and kind of boils down to what type of shock you're really looking at. And so, my first and foremost love is trauma. I do run the critical care unit, so we do see other forms of shock. And for us, we heavily rely on kind of crude data at this point. We're not leveraging sensors in the way that we should, in the way that I think the future will lead us to. And if you take it in the easiest way, if someone gets injured, let's say they have a gunshot wound and they're starting to bleed, we basically follow them over time through their ability to compensate, which is largely, only kind of the young people can do that well. And then we basically follow them. And so the first things that happen is that you actually give yourself, when you're bleeding, a little auto bolus of blood from your venous system. So all that blood that's pooling in your legs actually goes back into the system, because it doesn't need to be in your legs when you're actually actively hemorrhaging. And one of the first things that you'll see is actually the diastolic blood pressure, or that, lower number. So when you get your blood pressure at your doctor's 120 over 60, if we're doing really well with our blood pressure management, that 60 will actually increase a little bit. And so you'll see that narrowing of the pulse pressure, and that's one of the first things that we see. What's interesting is that because we're not utilizing sensors and we don't have kind of a panacea of, blood pressure monitors that are continuous, we actually get a bunch of really weird readings. So when EMS often brings in a hemorrhaging trauma patient with a serious injury, they often will tell us that, there was one low blood pressure reading of 90, and then there's actually going to be a hypertensive or high blood pressure that we see on the back end. And we see kind of this oscillation a little bit as the person's trying to compensate, and also at the limits of some of the, blood pressure cuffs that we have. And so we literally do a manual blood pressure cuff, where we take a nurse's time and we inflate a blood pressure to get a more accurate reading. The easiest actual thing to do that all the trauma surgeons do is we don't even care about what the blood pressure is when the patient arrives to us. The first thing we do is we just go and we start looking at the pulses. So I go and if the patient's talking, that's usually a good sign that they're perfusing at least reasonably well. I feel for a radial blood pressure, which is about a blood pressure of 90. I can't feel a radial pulse, then I realize either I have an injury that's causing a loss of the pulse, or maybe they're not perfusing that well. So the next thing I do, because we then strip down the patient, is feel for a femoral pulse, which is about a blood pressure of 80. If I don't feel a femoral pulse, then I know we're in trouble. And then we start feeling for carotids. And I can tell you, between that loss of the femoral pulse to the carotid pulse is when we start losing people's mental status. They get real sleepy, and I already know that they're in big trouble. And I have, at that point, even when a very young patient, they're usually tachycardic, they usually have a significant injury, and I know that I have less than 5 minutes to get them to the operating room before their heart's going to stop. So it's key to start, giving them some blood, transfusing, and coming up with the operative plan immediately. And sometimes that's just doing no more evaluation and getting straight to the OR so that I can control the bleeding as soon as possible. And then we make those decisions based on kind of crude things. Where are the injuries? What are trajectories? What do we think's injured? And ultrasound data, because we do not have time when they present that acutely to go to the CAT scan to really diagnose things in a standard way. So we have to kind of guess and get to the operating room where we can manage things.
Really interesting. It's very different than a lot of the other patients we talk about, where we have these cardiogenic problems that we know are
Right.
legit, but the time scale is so different. You have minutes, and really
10 minutes.
get into the OR, and I need to know kind of what are we going to do while we're running there. It's just really
Yeah,
interesting difference.
Yeah,
it's an
Casey,
art.
I was thinking the same thing. We talk on Perfusion Musings. We've talked a lot to people involved in advanced heart failure, And we often say that hypovolemic shock will look to a perfusion sensor a lot like cardiogenic shock,
Yes.
but it's very different, right? I mean, so you have a different mechanism. There's lots of bleeding that you have to get under control. Can you talk about that a little bit? How I think everyone's trying to preserve the vital organs, but how you control for them is a lot different. Can you talk about that?
I wrote that question down too, Dan. That's a great question. How do we relate cardiogenic and hypovolemic shock and differentiate cellular perfusion?
Yeah. Yeah, well, it's interesting because you're right. They are similar, right? Because there's something central, whether it's your blood volume or whether it's the pump of the heart that's not delivering the blood to the distal tissues. However, it looks a little different, right? So things that I'm going to notice is how pale the patient is. You literally will get, which I notice, a pallor in really dark skinned individuals, actually the bottom of the feet white out. And so that's really a key piece that is, something that we're not sensing other than with our visual inputs that AI is not determining and things like that. Now, cardiogenic shock, because it's usually related to heart failure, depends which side of the heart is going down, but there often is kind of an oxygen extraction problem. So if the right ventricle is not doing well, it's not, pushing that blood through the pulmonary circuit to adequately oxygenate. If the left ventricle is failing, you get back up into the pulmonary circulation. So those patients get a little bit more of a bluish take when you actually look at their fingertips and whatnot. So these little subtle things are actually key. But time is still of the essence, right? Because once you're noticing hypotension, which is honestly late, and I do want to underscore that I think there's an opportunity from point of patient pickup to hospital arrival that is underutilized at this point yet. Like we say we have a golden hour, but even in really great hospital systems, there's probably a 10 to 30-minute transit time from EMS pickup to the hospital where we could get a lot of data and really activate systems. But the key thing, and actually here we are with the loss of train of thought, the key thing between the difference is, everything is timed to perfusion of the distal end organs. And so, whether it's the heart not perfusing it somewhere, you're going to get lactate buildup, you're going to get malperfusion, and it's really timed to intervention, right? So that's whether or not you go to the cath lab and open up the artery, or whether you put someone on ECMO, which we're now trying to do on a faster and faster time scale, versus trauma, which is repairing the injury. And the key with all shock is that you somehow have to get, right? So the organism's going to compensate as best they can. What's really different in trauma is that tends to affect, especially things like gun violence or high-speed motor vehicle accidents, it tends to affect a younger population. So that compensation is going to be much more robust versus cardiogenic shock most likely is in the older extremes. There's a lot less reserve in older people, even starting, sadly, I'm 43. So, I have less reserve than a 20-year-old does. So they decompensate much more quickly. But the key is to get them back from the point where they basically get what I think is mitochondrially exhausted, where their energy supply, it's this level of shock that you can't pull them back from. And then you start getting dysregulated physiology. You're out of your compensation. There's kind of this poor perfusion. You send out a bunch of inflammatory markers, right, throughout your entire system that starts to dysregulate your normal response. And that's when all shock patients start getting high lactates or acid levels. That affects, high acid levels affects the ability for pressors to work, which is one of our main medications to treat it. It depresses the cardiac contractility, or how much the heart can squeeze once you get really acidotic. And then you start getting dysregulation of other things, right? Your kidneys start failing. You start getting dysregulation of your ability to clot. You either become hypercoagulable and make clots in places you shouldn't, or you become low coagulation. You can't make clot. You start bleeding from everything. And so we see that similar paradigm once the patient gets physiologically exhausted. And so because I'm making the point that time is of the essence, right? We can detect that earlier at the point of pickup and activate our systems to intervene and know that 30 minutes earlier, 15 minutes earlier, even 10 minutes earlier, the number of minutes to intervention is literally translates to mortality. And that's true in the trauma population, that's true in cardiogenic shock, and that's true in traumatic brain injury and stroke patients. So, and that's like a whole nother paradigm of shock, which is when the brain gets dysregulated and that causes you to have physiologic decline. And so while there's a lot of overlap, they're all distinct, but there's a lot to harness, and we're not really working as well as we could be in that pre-hospital space. Now, I'm going to yeah, if I can flash forward to one other paradigm, right? So I'm talking about the first hour of arrival, which is key, determines a lot of the interventions and the ability to save tissue that's being malperfused. But you have a similar paradigm in the ICU. So that's my other hat that I wear, as I'm an ICU doctor. Everything in the ICU right now, we collect hundreds of data points. People are over monitored. clinicians can't see micro changes in sensor data, right? So we're looking at EKG, we're looking at heart rate variability, but we're not detecting any of that. The only thing that gets my attention in a 30-bed ICU is, oh, so-and-so's not got a good oxygen level. And the level has to be at the point of end organ damage. Same thing when the nurses call me because someone's hypotensive and their blood pressure is not sufficient. They're getting end organ damage. And so how is it that we're in a heavily monitored, multi-million-dollar, ICU where we're looking at all these data points? We've got arterial lines measuring blood pressure with waveforms that we're not even calculating. We've got, potentially monitors on the brain if someone has a brain injury. And we're looking at all these perfusion markers that are much more crude than what's available to us. And we're still only responding when there's organ damage. Like the opportunity there to, know something's going wrong before that is there, but it's the cognitive load of being able to detect that and then alert people at a time where you can tell that this is a minor problem or this is a major problem, but we're getting to it an hour before the patient actually declines.
I think I'm obligated at this point to respond with AI, and then you just continue.
Yes.
Yeah, AI.
Well, yes, I agree.
If the
this is the key.
data exists, though, we hear again from our advanced heart failure colleagues, we hear a lot about microvascular perfusion sensing is inadequate, right? Everything
Yes.
that you just described is macrovascular, and so do you think that you talked about sort of mitochondrial dysfunction?
Mhm.
I often wonder is that I'm wondering what's the chicken or the egg? Is that because we're not being perfused enough, or is something happening to cause that dysfunction earlier, right? And
That's a good question. I think that depends on the pathophys, right? So you get a big crush injury, right? Where, maybe something falls on your body. That mitochondrial dysfunction probably is happening from all the crush injury. And there's actually this really interesting line of data. I don't know if you guys have heard of DAMPs and PAMPs.
not.
Oh, so interestingly, so your mitochondria was actually from a bacterial origin, right? That was passed on from some single mother that went to all of us, right? So when you get a crush injury and you release massive amounts of mitochondria actually out into your body, the first 6 amino acids on mitochondria actually are very similar to something called LPS, which is the same thing that makes you septic from septic shock. So large crush injuries with large mitochondria release to your system actually cascades an identical response to septic shock. So it does lead to dysfunction, shock, malperfusion. Now, a gunshot wound is very, very different, right? Because there's very little tissue damage. And so that is actually the malperfusion related to the loss of blood is actually what leads to eventually the mitochondrial dysfunction from hypoperfusion. So it depends. And cardiogenic shock, probably something in between, right? Because you're getting some malperfusion, the delivery of oxygen is also coupled with that heavily because your heart's not functioning well and you're not oxygenating as well. And that double load probably leads to significant tissue damage and death at a faster rate that then leads to continued shock, continued inflammatory mediators, and some release of some of these tissues as the cell die.
There are also a couple of different ways you can get into cardiogenic shock. You can have an AR,
Right.
or you can have a acute decompensated chronic heart failure problem, where you have different kinds of compensatory mechanisms built up in an HF population than in the AMI population.
Yeah, and the time scale is going to be key, right? Some people have like a little bit more chronic ability. Maybe they have a little bit more way of being compensated or whatnot versus someone that has an acute event that all of a sudden they have no flow to their LAD, and so they go into a massive MI, and that's going to be a really different pathophys versus more chronic presentation.
That actually brings me back to an earlier question I wrote down. You talked about how trauma is more in the young population and generally heart failure is more in the mid population, cardiogenic shock. I was really interested in the physiology that you described. Can you articulate some of the compensatory mechanisms that a trauma patient can mount versus the compensatory mechanisms that a cardiogenic shock patient or heart failure patient can mount?
Yeah, so I think some of the key things are just with the capacitance or the stretchability or the constrictibility of the blood vessels. So we already talked about the first thing that goes wrong when you start bleeding, that you give yourself an auto transfusion of blood from the venous system, right? So we always think of veins as not being very active, but they actually do have some contractility, and there's actually the ability to kind of squeeze blood out of the venous system. Again, it's much more, we all know this from varicose veins, right? Like When you're young, you don't have them. As you get older, you lose capacitance and all the blood pools and you can't really get it out. It's the same thing that happens across the system for the veins. Similarly, the arteries are actually even more important mediators of that. So when you're young, you have a ton of elasticity, you have a lot of receptivity. And I have seen trauma patients that literally may have an amputation of their leg, and the blood vessel, the main blood vessel in the leg, will vasospasm down to stop bleeding. So that there's actually a blood clot at the end of a major blood vessel, and it's that vasospasm down. In fact, when I go and repair those arteries, I often have to upsize the graft, because what I'm seeing might be something smaller than my finger in like a 6'5" guy. And then the next day when I come back, it's looking more like my index finger or larger, because it's the ability of the blood vessel to shrink. And we see that all the way from the microvasculature, more importantly on the arterioles and on some of the more distal extremity, because it's shunting that blood to the core. And so that's really different. And again, older patients, what do they get? They get calcium buildup in their blood vessels, right? That's what makes you lose the ability to squeeze and get that capacitance, and that kind of build in of a bone-like structure into the arteries is what leads to that chronic hypertension, right? Because you're no longer distensible and receptive on your blood vessels. You're just trying to basically put blood out of the heart against a bone. And that's what leads ultimately to heart failure. And so their ability to actually respond and squeeze and move is really different than a young person's. And so what that will translate to is that young people look really good until they're about ready to crash, and they'll have extreme tachycardia. So I know usually they look normal. I've even had trauma patients with massive injuries talking to me, looking good. And then within 10 minutes, you will also get extreme tachycardia, and then they just fall off the cliff into arrest. Older patients either are in arrest earlier, so when I see them, they're already pretty decompensated, or very minor things like bleeding from a little tiny spleen injury plus a little tiny liver injury that wouldn't have affected a 20-year-old is really affecting them, because they're off and out of their equilibrium, because they have a little heart disease, their blood vessels can't augment, and then God forbid you add in some medications, which most people are on, right? What do we do to old people? We make their blood thinner so they can't clot, and then we block their ability to augment their heart rate, right? So minor bleeding, the way that your body will make up for that in a young system, besides constricting all your blood vessels and giving the blood back to the core, is that it will augment the heart rate to maintain the volume of blood that's coming out from the heart. And when you can't augment your heart rate because you're on a beta blocker, you really have zero reserve. So that compensatory reserve is basically, in a lot of patients, non-existent. Now, there are some other outliers, right? Kids, massive, their compensatory reserve is like, they are talking to you, they look great until they absolutely fall off the cliff. It's even worse than a 20-year-old. And pregnant patients, right? Because women's bodies, especially as they move through the trimesters, are completely built to sustain hemorrhage, right? They're basically expanding their volume. They look really good. They have all this inbuilt capabilities to sustain the bleed of a birth. And so they look really good if they're traumatized until they're about ready to fall off the cliff. And then you have not just one, but potentially a second patient, especially if it's very late term, to treat and manage their perfusion on.
Oh,
Let's
rewatch this now just to ask more questions.
right. Let's
Yeah.
So let's talk about maybe the other side as we start to resuscitate people and they get better. You
Mhm.
mentioned being in the ICU. You notice when people are only certain things get your attention when they're crashing.
Yeah.
What do you think perfusion looks like, or what should we be looking for as they're getting better? When you say, "Man, we made it. We're through the valley."
Yeah, well, there's two valleys. There's like the acute valley, like you're bleeding, and there aren't really great perfusion markers, right? Like hemoglobin really lags behind. Lactate clearance is kind of key. For me, it's again, patient's color really matters. And actually, I think there's two check boxes on that. There's like, I got you through your initial major blood loss or whatever, your heart attack or what have you. And then there's like, they still are sick and not doing well. And then like a week or two later, they get their real color back. And I always say it to my patients when I walk in the room. I go, "Oh, you finally got your color back. Like now I really know you're on the mend. We're not in this kind of like fully drained capacity." And so there's really two different views that at least I can detect as a clinician. Like one is like, you're through your near death. And then there's the second one that's like, oh, now you're on the path to health because you've like recuperated enough. And that's actually quite delayed. And I don't have a contextual feature for that because I don't see it in the labs. I don't see it in the vital signs. It's just literally they look better. And like you guys probably have seen this, like people getting over a cold, like they look awful for some reason. And then you're like, hey, you look better today. Like a week later, like you're no longer diverting all your energy to something else. And so I think those are kind of key things. Lactate clearance, blood pressure is key. for us, and I get the luxury of having all these monitors because I'm an ICU doctor, and all my really sick trauma patients tend to go to the ICU. But we still can't tell who's fully better, right, versus who's still at risk for a complication or a second, issue that's going to then lead to malperfusion, right? Like maybe you get shot and I put your bowel together. One person's going to look great and continue on that trajectory, but then there's like this other thing where like, I have to have that heal. And if that's not healing, then they're going to get sick and get septic again. And, it's a late find. It's with labs, a white count elevation might be pain related, that they're having more belly pain. Sometimes their normal bodily functions don't come back to normal, right? Like they might not have normal bowel function. They might have high, drainage from their stomachs and stuff like that. And it's really that normalization of all the processes, things that are in the sympathetic world kind of normalize down, and they get lower heart rates, they get better blood pressure, they make good urine. Day 2, day 3, they start autodiuresing and peeing more. That's a really good sign that they're on the mend, and they're probably dropping down some of their cortisol. And then those are the big things that I know they're doing okay. And when I don't see those things, and I still see them retaining and kind of stopping up a lot of need for fluids and things like that, then I know I probably still have a problem. But when the urine output doesn't come back online, I know I have a problem there, because I want to see that. And, the really sick patients will sometimes be on dialysis, so that can be extremely delayed. But in the acute trauma patient that you fix and go, that should be something that's returning within 2 or 3 days. Same thing with any surgical post-op patient.
Yeah, it sounds like it must be really challenging to figure out who can move to a lower level of care, which is, I imagine,
Yes.
a constant pressure from the hospital, move people down to less expensive care. And
Yes.
then maybe, but it just sounds like a large challenge to figure out who's right. What risk are we willing to take to move them to a step down or even home?
Yeah, there's greater and greater pressures on that. There's less and less beds. I think especially the level 1 trauma centers, the academic centers are really being overwhelmed by a lot of patients. We're constantly full. We're constantly in some sort of code disaster. Like that's a normal thing nowadays, where it didn't used to be. And yeah, there really is that pressure. And the second part of that is when you do downgrade someone and they bounce back, they actually have a much higher mortality than if you didn't downgrade them and they never returned, right? Because there is some delay that's incumbent in that, number one. And obviously they have sustained a complication, but it is a pricey thing when you mistriage someone out of the unit too early. And it does lead to, I would say overall, a much worse patient outcome, whether that's for respiratory dysfunction or for, some sort of complication or shock. The other problem is, right, like, and we've talked a lot about this, is there's a whole other group of patients that are in the ICU, which are the patients that are just there for monitoring, right? Because we're still doing things kind of the old fashioned way, where we're doing, every hour vascular checks or every hour neuro checks to check the brain. And that group of patients may not need the ICU. What they really need is one-on-one or 1 to 2 nursing care. And, that competes with resources for these other sicker patients. And so again, as we start stepping into this new phase where we can monitor things, or we can think about perfusion monitors, those would be things that will allow us more bandwidth to have more ICU beds, because we're not going to need to dedicate those resources just for monitoring.
It sounds like we need some more monitoring at the step down unit. I was going to ask some questions about
Yeah.
what you might want in that space, or you cure one kind of shock only for another to appear when you're not expecting or surveilling it. You mentioned respiratory depression. What other kinds of monitoring would you be interested in that step down unit, and how would you use that? And when should we trigger warnings, and how can technology
Yeah.
contribute to that uncertainty?
Well, the warning fatigue, I think, is right now the real devil in the details, right? Is like, when do you alert clinicians? When do you not? You can't have alarms going off all the time. And I know a lot of people in that space, that's the number one thing they're doing, is just dampening down signals, because there's always something. But I mean, the things that I would be looking for is, obviously the big things: heart rate, blood pressure. I think there's probably some contextual things like heart rate variability, that when that comes back, that's a good sign. When it goes away, that something's brewing. And again, that's that diversion of energy away from probably the time fluctuations that you have and your receptivity to changes in your own physiology. O2 saturations are huge. Little respiratory changes, I think, are big. And then we've talked a little bit about this. I think there's probably even room for like some deltas, like when you start shunting blood to different areas of your body. If we could build something that could detect that, that would be amazing, right? Because your body again, to getting to that compensatory reserve. If you can catch someone while they're compensating before they get to end organ dysfunction, you're going to save them a significant burden of injury to their organs. And so, when you can see that the body's doing stuff to shunt blood that's starting to compensate in ways that are not normal compared to their normal physiology, that's the window that we need to start capitalizing on. We want to be proactive, not reactive to whatever derangements are going on.
You, I know you're very active in the AI space and vision about use of AI.
Yeah.
You kind of touched around it. Do you want to talk specifically about how you think AI tools can be used to assess patients in this space as much as you're covering?
Yeah.
I know you have some good
Yeah.
ideas. You might not want to share them all on the podcast.
Well, no, I mean, the two big areas for me are the pre-hospital space. I think, we have amazing providers. They're so well trained in terms of the EMS and pre-hospital groups. And I think we can upscale them. And I think we can also do a better job of triaging patients. So one of my other jobs is I am vice chair for surgery. And all I do is think about where we are bringing patients in a system, right? So, starting at point of injury, am I bringing patient to our level 1 and then have like 8 patients that didn't need us for every 1 patient that we accidentally sent to the level 2 that maybe didn't have the resources that they needed? And then I also have the financial model, right? The healthcare is not doing very well. In order to remain viable, you basically need to keep all the hospitals within your system about 95% full. You don't want it 110% full because then that affects patient care. You don't want it 60% full because then you can't make the books, even, and you're losing money constantly. And so, thinking about how we can use AI to better diagnose things in the pre-hospital space. Like, I don't use a lot of tech, as I told you. I may not have a CAT scan or anything, but I, as a trauma surgeon, can diagnose someone extremely well in the trauma bay in 10 minutes. There's no reason that can't happen in the pre-hospital space with AI augmentation, right? You can upscale people with less training. You can use sensor data. You can use a bunch of different things. And that will make the diagnostic accuracy of who goes to level 1 trauma center versus who goes to level 3 because they just need to be watched and monitored, but actually are probably not going to decompensate, a probable easier thing. And, right now, all those patients are being brought to the level 1 trauma center, and then we're kind of wishing we could send them to the level 2 or level 3 when we get super busy. But there's not really an easy way to do that because you got to call another ambulance that's double charge, downgrading. You can always upgrade in the system, but downgrading is fraught with legal, problems. But we're under leveraging the support structure of a level 2 and a level 3. So that's one. Number 2, I talked about that 30 minutes, right? Before, while you're transferring in really mature hospital systems, that's key. But what happens is the patient arrives 30 minutes into their injury pattern. And that's when I'm starting to activate massive transfusion. That's when I, as the trauma surgeon, am activating the OR. And that's when I'm saying, all right, this is the plan for what we need to do. Wouldn't it be nice if I have all that same data in the field to start doing that at time 2 minutes instead of at 35 minutes? Like, that saves us 20 minutes of time. It allows the blood bank to start thawing FFP. And while we have some pre-thawed blood, for a trauma patient that's going to need a lot of blood, like, we actually do need some time heads to be able to get that blood kind of thawed and in the right ratios to deliver. And so all those things are key. And then, God forbid, you need a specialist, right? Like, maybe there's some complicated major vascular repair. I do my own vascular as a trauma surgeon, but there are some things that are out of my wheelhouse. And if I got to call in even at a level 1, one of my colleagues, it might be 45 minutes out, an hour with traffic, to get them set up. Wouldn't that be nice to figure that out 20, 30 minutes earlier? Like, the patient's only going to get better care. So that's the other piece. And then my final bucket, because it's 24 hours of continuum is key, is that ICU bucket, right? I think there's so much data that we have that are like little micro changes that we can't detect as humans because it requires too much cognitive load looking at the way the sensor tracing is changing over time. But I am fairly certain and have a very strong hypothesis that, if you could get good at looking at some of those micro changes on the way your pleth is going, that you're going to be able to detect some problems much earlier than when we are reacting. And so it's enhancing that capability, determining things before they start getting to that end organ dysfunction. Because, if I had my way, we would be doing all this stuff so much more fast, and we'd be detecting patient deterioration and decompensation after surgery so much more quickly than we currently are doing, not when they're crashing and burning. Like, that would be a failure. And I think the tech is there. The key thing, as you mentioned, is the data, right? How do you get all this heavy data and process it in a central way? How do you train it? How do you train it in a way that is transparent and docs know and can trust it? How do you know the outliers that maybe aren't going to fall into the training that you see? And where are you going to make mistakes? And I think those are key things that we need to think about. I work at Boston Medical Center. It's a safety net hospital, I'm extremely worried that the safety net hospitals that provide care to people that are underinsured are going to get left behind in kind of the monetary grid of, upscaling, putting in sensors, doing these big AI build outs, because it's right now very expensive to do. And so I'm really trying to fight for a piece of space where, we can still fight for the safety net to do it just as well as the other, maybe for profit that might be in town, that I think is key. And quite honestly, I think if we can't do it in Massachusetts with a supportive government and whatnot, it's going to be really hard to do anywhere. And so I think we really need to stake it out. We need to think about our ecosystem. And the final thing that I think is super interesting is we need to think about creative pairings, right? Like we've always kind of developed these things, either industry did it alone or academia did it alone. And I think this is really a time frame where we all need to pair in a way that we've never paired before, because academia can't keep scale with industry, and industry needs academia and clinicians to weigh in, not just one PI, because that's too limited a viewpoint for big swaths of AI data. You need like panels of expertise to really vet it in a way that's going to be clinically meaningful. And so rethinking that structure, I think, is how I'm trying to think. On multiple levels, whether it's at the system level of patient delivery, the academic research infrastructure, or if it's just how do you process the data on a single patient with millions of data points. I mean, they're big problems, but they all need to be drilled down upon.
You're right. And I think it's probably no surprise to people listening to the podcast that we know each other. We've been talking about these kinds of problems. The one group that you didn't mention is the American service member, and our interest is
Yes.
learn from the military environment. We don't need to talk about that on this podcast, but there is a huge opportunity to learn from the injury patterns in battlefield medicine that happens there as it translates into the civilian trauma space, and understand how perfusion evolves in sometimes much better integrated care systems because they're controlled by one commanding general than they are across the level trauma systems that we have in the US. This has been a great.
If I could just close on that last piece, because I am funded through, our warfighter and through the Department of Defense, but I actually think that the key thing there, right, is that civilian have always benefited from developments in the military space, and the military has always been benefited by the civilian space. They're not that separate. The problems that I'm talking about can be completely drilled down to role 1, role 2, role 3, and other things that are coming up. And the injury patterns, actually, the stable construct is the human being. We break the same way every time when you apply certain forces. So you can layer that stuff, even though the mechanisms of injury might be slightly different in terms of force multipliers. And so there's so much to cross-fertilize between those two groups that I would say, while there are nuances between the two groups, they actually benefit one another to be researched together for the good of all.
And maybe we should have a military trauma surgeon, military cardiology expert on here at some point.
It's a good idea.
This has been a great conversation, Noelle. It's great to have your participation. We, like I said, I'm going to go back and listen to this probably 2 or 3 more times before it even posts, so I can think of more good questions to ask you next time we see each other.
Well, it's always a pleasure. I love talking with you guys because you always, make me think out of the box, and, you're pushing the limits of like what we can do, and that's where we need to go. So.
Well, thanks for spending some great time with us today. We'll look forward to seeing you again soon.
All right. Thanks so much for the time.